Well, welcome everybody. It's wonderful to have you all with us. I'm Evelyn Brealey, and I'm the lucky person who directs Cambridge Global Health Partnerships. And we're really pleased to have this opportunity today to hear from some of our project leads and some of our colleagues about their experience of COVID-19 and health partnerships during this time. And thinking about that question of, can we build back better? So before I hand over to Dr. Mike Moore, who's kindly chairing today's session, just a few things. Please remain on mute. Please use the question and answer function, which is at the bottom of your screen, to post your questions. And then we will have a chaired panel session at the end that will seek to answer those questions. If we don't manage to answer all the questions, we will answer them on our website and send you the link after the session. And obviously look forward to ongoing conversations about today and both the questions and the presentations. So yes, I hand over now to Mike Moore, who's the chairman of Cambridge University Hospitals. And we're very grateful to Mike for doing today, but also for supporting Cambridge Global Health Partnerships more generally. So thank you, Mike.
Thank you very much, Evelyn, and good afternoon or good day or hello to everybody from wherever you are. So it is I'm very glad to be able to have this opportunity to support Cambridge Global Health Partners. The partnership is a very vital and essential partnership that we're engaged with, and we see it as very fundamental to our healthcare mission. For reasons perhaps I'll explain a little bit later. I'm delighted too that I think amongst the participants in the discussion this afternoon is Dame Mary Archer, and Dame Mary was my predecessor but one as chair of the hospital, and in that time she established, as it was then called, Addenbrooke's Abroad. It's recently become Cambridge Global Health Partners, and it was a very important initiative, and I'm delighted that it is going from strength to strength and continuing in the way it is. I was asked to just give a couple of reflections on charitable, on our experience of COVID, and one of the connections is that charitable element. We found across the whole of the United Kingdom, as our experience of COVID, that people's valuation of the health service has in many cases been reflected in charitable donations, and those have been very welcome. But in addition to that, we have a sustained charitable mechanism within the hospital, which has supported clinicians, nurses, and all the various disciplines involved in healthcare over this period, and it's been hugely valuable. And I'm delighted to say that that Charity Act is also the umbrella sponsor for Cambridge Global Health Partnerships. So it too sees its charitable endeavour to support activities such as we're doing today. I've just got four wider reflections, if you like, on our experience of COVID. First of all, it shows that we live in a very big world. People in the West, in developed countries, sometimes, or some people, hopefully a minority, have a view that we can control the world. And I think the pandemic and other phenomena like global warming just goes to show that we're not quite in control. And this is a very big world, and it's a very a world that we will continue to have to try and understand and develop our responses to it. And the pandemic has shown that with a vengeance, as of course previous pandemics in the world have also shown. We chose that we have to treat the world with respect. And it also is very big in the sense that it affects billions of people. Second thought, though, is as well as being a very big world, it's a very small world. Of course, we know a lot about viruses, and we know a lot about vaccination and therapies, etc. But this is a new disease, and we've all had to learn together. We've all had to learn as a health community across the globe as to its phenomena, its characteristics, and what we can do to respond to it. And we're continuing to learn. And we're also a small world in the sense that things like today, the webinar and Zoom and things of that sort, enable people from across the world to come together in a way that perhaps is unprecedented, and I think will probably be an establishment for the future for many of our activities. The third reflection on it is that it does raise some very profound ethical questions. In the early stages of it within Addenbrooke's, the ethical question, or the expected ethical question, was how are we going to prioritise patients for very scarce resources, particularly critical care? Interestingly, that tended less to be the issue. The issue was how do you prioritise whole groups of patients, the non-COVID patients along the COVID patients, and how do you prevent the impact of lockdowns or the economic consequences of COVID not to create long-term health consequences. And final reflection is that it is an opportunity to rebase our learning. There's much that we've learnt in Addenbrooke's which we will wish to continue for the future. It's given clinicians confidence in important ways. So those are just a few reflections from me as to our experience in CUH. We're now going to hear from, hopefully, three colleagues. First of all, Jamie, then Thinn, who I can see has joined us from Yangon in Myanmar, so delighted, Thinn, that you're here with us. And we haven't yet, at least at the time of starting, heard from Sani, who's in Nigeria, but hopefully he, during the course of the discussion, will be able to join us. So I'm now going to pass over to Jamie. Jamie is a consultant in infectious diseases and microbiology here in Cambridge at Addenbrooke's Hospital, and he co-leads the Kampala-Cambridge Partnership and has had a long-term interest in global health issues. His PhD from Oxford was in dengue fever in Vietnam. So over to Jamie.
Thank you, Mike. As Mike mentioned, I'm an infectious diseases and microbiology consultant at Addenbrooke's, and I'm the Cambridge lead of the infection control and antibiotic stewardship component of our Uganda-Cambridge partnership. I'm going to reflect on our partnership that we have with Uganda and how that's changed in light of the COVID pandemic. So just a bit of background. So the Cambridge-Kampala partnership, it actually started prior to 2014, initially with a research project between the University of Makerere and the University of Cambridge, looking into preeclampsia. And in 2014, a partnership between the obstetric team at Addenbrooke's and the obstetrics department in Makerere began. And the remit of that partnership was to improve maternal and neonatal health outcomes. That worked very well over a period of years, and it's an ongoing activities between the obstetrics department in Makerere and in Cambridge. But in 2019, an additional strand was added to the partnership. And this was framed around antibiotic stewardship and infection control. And this was, we got funding from the Commonwealth, from the Fleming Fund, supported by the Tropical Health Education Trust, to support our project in Uganda. And it reflected an awareness of the importance of infection in causing maternal and neonatal morbidity and mortality. What this project really did, so we basically the task of the project was to really work on antibiotic stewardship and infection prevention and control. And a scoping visit back in June of 2019, long prior to COVID, kind of made us very aware that the main thing to focus on initially would be to focus on infection prevention and control, and then from that build on antibiotic stewardship activities. So what we did in September of last year was deliver a training course, which is a multidisciplinary team from Addenbrooke's went out to Uganda to do a training course framed around antibiotic stewardship and infection control. And that comprised nursing staff, pharmacists and doctors as well. And we worked very closely with similar professional colleagues in Uganda. We also hosted a Ugandan team in Cambridge last year as well, where the learning and the partnership could grow. And one of the big achievements really was to try and promote the use of alcohol gel within the hospitals that we were working in. And we did that really by empowering the pharmacists to make alcohol gel themselves within the pharmacy departments of the hospital, so that it could be then delivered to all the clinical areas of the hospital. And this is really important because the water supply in some of the hospitals that we're working in was unreliable at times, which means you can't really rely on that as a hand hygiene strategy. So what this really did was put infection prevention control activities as a central focus for the hospitals. So we increased the awareness of these issues and really highlighted their importance in the hospital activities. And from that, the idea that antibiotic stewardship and prevention and control of prescribing, etc., would then develop from a good platform of good infection prevention and control strategies. And then, of course, coronavirus, as we all know, has been a big part of all our lives for the last several months. So within Uganda, the sort of shape of these epidemic curves will be familiar to all of us, but the epidemic in Uganda is some way behind what we've seen in Europe and North America. But it's important to note that Kampala, where we've been working with, is the center of the epidemic in Uganda. There's been a lot of transmission within healthcare settings, and working within Kampala is absolutely key to controlling this outbreak. One of the important things to note is that Uganda has put in place a very, very rigorous lockdown that was eased to some extent in June, and further eases happened this month in September. But the effect of that lockdown has been significant. So there's been work from the University of Makerere showing that babies born since lockdown was implemented have been of much lower birth weight than those born before lockdown was implemented, which just shows that trying to control coronavirus has got there's a consequence to the activities that we put in place to try and control coronavirus. We know that ourselves from working here in the UK, that many things have been delayed or deferred as a result of coronavirus, but the health impacts in areas where the health systems are less strong, less robust, are significant. And I think it's really important that we bear those in mind when we think about coronavirus in Uganda. So what we've done within our partnership is secure extra funding from THET, the Tropical Health Education Trust, through what they call the Health Worker Action Fund. And this really provided additional funding to support our Ugandan partners procuring scrubs, maintaining the manufacture of alcohol gel in-house. So we'd already started that program, but we wanted to make sure that it was going to be maintained throughout coronavirus and give the pharmacists, empower the pharmacists more in that activity. In addition to that, we've been having ongoing dialogues with our Ugandan partners through regular WhatsApp and FaceTime conversations and conversations on Zoom as well as sharing our learning resources that we developed in Cambridge, some of which will not be directly applicable, but the principles are there that we're trying to share what we've learned with our Ugandan partners. This has helped promote infection prevention control activities within Uganda, within the hospitals that we've been working in. And I was in contact with Musa Sekikubo, who's the obstetrician, who's the Uganda lead of this partnership this week. And he said that what's been a real success from this partnership is really driving up infection prevention control activities up the agenda of the hospital management structure. People are now all aware of these important areas, and there's been a much, much bigger focus on these activities, which will have a positive effect on COVID itself, but hopefully going forward will help us and our Ugandan partners achieve the aims of the partnership in terms of improving outcomes for patients in the hospitals that we're working in. So just a bit about the impact on our partnership. So obviously, like all of us, we've had to deal with many negative impacts. So we were due to go out to Uganda in March of this year. That was put on hold for obvious reasons. And many of our antibiotic stewardship activities, particularly about antibiotic consumption, the development of antibiotic stewardship committee groups, has been put on hold while we focus primarily on coronavirus and infection prevention control. But some of the effects of this outbreak have been positive. So I've seen this phrase bandied around a lot, that we're physically distanced but socially connected. And I think this is very, very true within our partnership. So I think that despite the fact that we haven't been able to go out to Uganda, we haven't been able to host our partners here, we've actually in many ways had more contact and more dialogue than we would have had perhaps under normal times. I've put in a quote here from Ronald Onegwa, who's the pharmacist that we work with primarily in Uganda. And this just summarises how he feels that COVID and also the activities that we were already implementing in our partnership have had a positive effect on the hospital as a whole. And I think this is something which we really hope that we can build on going forward. I think it's also important to reflect on the positive effect on us here in Cambridge. I think that certainly back in March and April, the infection teams were very, very tied up and very, very focused, understandably, on making sure things were safe and effective within Cambridge itself. But it was really, really helpful for us in terms of our overall well-being and our outlook generally, to have a more global perspective on things and realise that we're very much not alone dealing with coronavirus. So we know that from reading the news, but in many ways, connecting with partners who are dealing with challenges often in a much, much more difficult context really helps feel very grateful for the situation that we have here, but also very aware of the responsibility we have to some extent to share what we can to help our colleagues working in much more difficult settings. So going forward, I hope that the closeness that's been forged through this difficult time, we can build on that and grow our partnership back on its original themes, but keeping the infection prevention control activities very, very at the forefront of activities within our partnership, but going forward for the hospital as a whole. I think that this has really reminded us of the central importance of infection control and how important that is. And I really do believe that, ironically, not what you necessarily expect when you can't travel out there, but this whole pandemic has resulted in stronger links and firmer foundations that we can build on when we go on working with our partners in Uganda. Thank you very much.
Thank you very much. Thank you very much, Jamie. That's terrific, and certainly a lot of those points resonate with me. What we'll do is we'll hold a general conversation back until the end of the presentations, and I'm delighted to say that both Thinn and Sani have been able to join us, so that's wonderful to have you join us. It's good. So we'll move on now. So if participants if they have questions that are prompted by Jamie's point, hopefully we can pick those up a bit later. So I will now hand over to Thinn, who's a consultant in clinical pathology and the co-lead of the Yangon Cambridge Partnership in Myanmar. And she was a consultant, or registrar rather, here at Addenbrooke's a few years ago, and went back in the first instance of volunteer capacity to Myanmar to continue the partnership. So I'm delighted to welcome Thinn, who I hope is still with us, and who's going to talk to us about her experience in Myanmar over this period. So over to you, Thinn.
Thank you very much, Dr. Moore, for your kind introduction, and CGHP for asking me to participate. I just want to check with Sophie whether you are sharing my presentation, or shall I share my screen?
You could share your screen, then that would be great. Just the green button green button at the bottom.
Sure. Sorry.
Okay.
Can you see it now?
Perfect. Perfect.
Yeah. Yes. So Cambridge Trauma Intervention Project is the very long partnership between Cambridge and Yangon, and started since 2013. It started with pathology and trauma. But after 7 years down the line, it has expanded to many multidisciplinary partnerships, which includes clinical skills, physiotherapy, ICU, nursing, and now neurotrauma research as well. We have done many exchanges, both short and long term, during this 7 years period. And the photo on the left was taken exactly a year ago, when the senior leadership team was visiting Cambridge Trauma Center. And this photo on the right was taken at Yangon General Hospital in February last year, after finishing ICU training. So we had so many impacts during those 7 years, but with the COVID hitting the whole world, Myanmar is no exception. For those who doesn't know Myanmar really well, it is a country, one of the Southeast Asian countries with 51 million population. We are bordered by China, Laos, Thailand, and Bangladesh. So we have both formal and informal entry points along these borders. So when COVID first hit Myanmar in March, end of March, the first cases were due to the people coming back to Myanmar who were working in these border countries. But many people might have noticed that Myanmar is one of the countries with very low numbers of COVID deaths and cases between March and July. And very much like what Jamie said, the scenario in Uganda is very similar to Myanmar. Because of the very low cases in Myanmar, the restrictions were eased gradually in July, and with the ease of these regulations and travel, internal travels, we have now, within 1 month, the cases have been tripled and more than that. And now we have more than 6,700 cases with nearly 120 deaths up to today so far. So how are we coping? In terms of the travel, we have implemented very rigid public health restrictions. So there have been no outgoing nor incoming flights since March 30th, international travels. And internal travels, there were restrictions until July, and only a month ease of travel bans. And now it has already stopped. And for the previous capital of Myanmar, Yangon, all the townships are now almost total lockdown condition. All the schools and universities are closed, and restaurants are only providing takeaway services. So all these measures have a very significant impact on Myanmar. In terms of clinical management, there are 3 COVID dedicated hospitals in Yangon, Wibagi, South Okalapa, and Paungji COVID hospitals. But with the cases escalating every day, so today we have one of the highest positive cases with nearly 700 cases. We are now struggling to find beds, and now tents and emergency hospitals being built in on the grounds of the football pitches, and some condominiums, newly built condominiums, have been converted into the accommodation for less ill and asymptomatic COVID-19 positive patients. So Myanmar is one of the developing countries, and its social security systems are very much weak at the moment. So the very rigid public health restrictions, such as the lockdown and the restaurants and the internal travels, have a significant impact on the public, especially for day-to-day survival. So they're not just health well-being, but their emotional well-being, economic well-being, and political stability is also affected. We have upcoming election in November, so that is also in danger, whether we are going to go ahead with it or whether we are going to postpone. And it is undoubtedly a very challenging time and significant pressure on healthcare professionals, because already we are starting with a very low healthcare professionals and patients ratio. So for example, there are only 200 anesthetists for the whole country. So if we are expanding ICU, and if the anesthetists are going to be leading these services, that is a significant challenge for all of us as well. So what does that mean for CYTIP, Cambridge Yangon Trauma Intervention Partnership? So we have planned for the training visit in February, but that was cancelled because the COVID was starting at that time. And with the COVID raging in both of our countries, we have competing priorities. So in Cambridge as well as in Yangon, the ICU services are under pressure, and the specialists working in these areas have very little time to engage. And that is same for the pathology areas as well. The human resources is greatly stretched, and because of that, their motivation, their well-being, these are also very much under stress as well. And again, because Myanmar and Yangon, there is a significant time difference, when 5.5 hours time difference. So if Cambridge people wants to do a seminar in the evening time, that would be very late in Myanmar. And there is also, if the virtual interaction is not quite the same as the physical interaction, and hence the language barrier becomes more, can be more challenging when we are engaging with one another as well. Despite of all these things, all of us has learned many lessons during this pandemic. The most important thing is that everyone has now agreed that world is one family, both for adversities as well as for opportunities. So the pandemic has taught us that we have to be united to overcome and to win against this pandemic. And also that learning has to be bi-directional, and both sides and partnership has to be committed to get this partnership working. And lastly, that people are the heart of all these partnerships, and all the opportunities as well as problems and solutions to the problems relies on these people, and we need very committed, trained and creative individuals. So we have to build back, and we have to restore our partnership, our strategic planning. And for this, the most important thing is that we need many people who are motivated and engaged, who will be able to lead, and who will be also be a part of that team as well. And we need to have a strategic planning, so that we need now to look at ways of adapting our partnership, how we will go forward, because the world will not be the same as before. So we have to be able to flexible and adapt our plans, so that everyone can include and continue with our training and learning processes and exchanges. And lastly, we need to be able to explore more opportunities, how we can connect to each other using the technology and innovative ways, and also using available resources. So with that, I would like to thank you all for listening, and I hope everyone will stay safe as well.
Thank you very much, Thinn. That was fascinating, and really, and so for you it is 11 o'clock in the evening in Yangon at the moment, is that right, or just about? Yeah, yeah. So that was fascinating. And again, if I can ask participants if they've got questions, there are some, again, for me, big resonances with what you'd said to our experience here in Cambridge and from what I've seen elsewhere too. So really fascinating, and really interesting to see the way in which the infection rates have increased when the relaxations took place, and the reimposition of those as a result. So no doubt lots of questions. I've got lots of questions I could think of in the context of what you said. So thank you. We'll come back to that after we hear from Sani, who I'm delighted to say is here. So Sani, welcome. It's great to see you. So Sani is, again, CUH consultant in infectious diseases and microbiology. So a fellow consultant in the same specialty as Jamie, with whom we started. But Sani, you're currently away from Cambridge University Hospital because you're acting as the coordinator for the Nigerian Presidential Task Force for COVID-19. So really, really major role within Nigeria, and that succeeds also a time when you were working as coordinator for the control of AIDS in Nigeria for a couple of years as well. So that's clearly you're very important to Nigeria. So it's good to have your time here. So over to you.
Thank you, Mike. A pleasure to be with you all, colleagues, and thank you for inviting me. I'll try and see if I can share my slides. Yeah. Can you see my slides, Mike?
Not yet, Sani.
Okay, I'll give it a few minutes to come up. Let me try sharing it again. Now let me go to share slide. Okay.
Great, it's working.
Okay, excellent. So thank you once again for inviting me. I left for Nigeria in mid-March when I was asked to come over and help with the COVID response. This was at a time when we were just starting to see the first few cases of COVID-19 in Cambridge. And I didn't really realize at the time how bad it was going to be. I left with the assumption that I'll be back around Easter for Easter holidays. But of course, Nigeria closed and the UK closed as well. So here I am 6-7 months later, still stuck in Nigeria. But anyway, right. So just try and see if I can move my slide. Yes. So back in February, in late February, the first case of COVID was confirmed in an Italian gentleman who was diagnosed in one of the southwest states. And so by mid-March, I was contacted to come over to head what was a presidential task force on COVID-19, really set up structurally very similar to the US presidential task force at the time. Within a week, we had started implementing measures. We closed the international airports on the 23rd of March. A week later, we started the process of locking down. And by the 4th of May, we locked down for about 5 weeks. Now, we didn't lock down the whole country. We locked down some of the states that had issues at the time. But subsequently, some of the state governors took decisions on their own to lock up their own states as well. By the 5th week, we were starting to have issues, socioeconomic concerns. In fact, we were told quite clearly by the security agencies that unless we relaxed some of the measures we had imposed, we were likely to have serious security issues. There was a significant risk of public disturbances. So we had to relax, even though we were not entirely ready, and we continued to monitor. And you can see our cases. We started off with 1, 3, moved on to 70. By the 4th of May, we were in the first couple of thousands, and we're now just about 60,000 cases. So what did we do? I think as a task force, we've really worked very well together. The task force is made up of ministers, 9 ministers, the head of the National Security Agency, as well as the head of the National Center for Disease Control, the equivalent of the PHG or the US CDC. And we started off by revising the case definition and worked on improving diagnostics. We had only a few labs that had the potential for delivering molecular services, mostly Lassa, in relation to the Lassa outbreak that had been going on in the country for a year or two. So we increased the number of molecular labs. We now have just about 88 laboratories, including about 18 private laboratories offering diagnostic services with regards to COVID. We started the process of international travel restrictions. We instituted the lockdowns. We locked down borders in between states. And after that, we then started slowly relaxing. One of the key things that we introduced was mandatory masks and social distancing. And I think we started introducing this a little bit earlier than the UK. In the UK at the time, there were a lot of debate. There was a lot of debate as to whether really using face masks really made a difference. It was only afterwards that the evidence became quite glaring. But we had already taken the pragmatic decision right from the beginning to start using face masks among the public. And then we shut down schools, places of worship, and intensified risk communication. So what were the sort of achievements to me? What have we achieved? Well, first of all, the entire program was run in a very coordinated manner. I was quite surprised. Usually government agencies, based on my experience in Nigeria, tend to fight each other. But this time around, everybody came together. The elite in Nigeria have always been very good at uniting when they have a common enemy, adversity. And I think this worked very well. I can remember the experience we had with Ebola. It was fairly similar. Whenever there were clear risks when it comes to life and livelihoods, usually the country tends to come together. So we had numerous coordination meetings. We started off with daily meetings and daily press briefings, and we've now sort of come down to twice weekly meetings. We also started the process of generating resources for the response, including World Bank funding and funding from our partners. I've already mentioned that we've deployed a lot more laboratories than we first started with. We also had a lot of rapid response teams, and we changed our strategy. Initially, our strategy was to try and bring down the epidemic throughout the country, but we subsequently realized that about 20 of what we call the local government areas. This is the third level of government. We have the federal, then the state governments, and then we have local governments, the equivalent of sort of counties. So about 20 of the counties in the country were responsible for almost half of all infections. So we started targeted interventions in these areas. We put in place infection prevention and control. In fact, if there's anything that we have benefited from when it comes to COVID, if you can ever benefit from a pandemic, it's really the switch to prioritizing simple infection control and prevention measures, such as the provision of hand washing facilities in medical wards and surgical wards, etc. Something that was really lacking, improving basic hygiene in our hospitals as well as within the public space. Things have really changed since March this year. So we set up a lot of treatment centers, 131 in total. Initially, one of the mistakes we made was we copied the West in terms of setting up temporary facilities. But it turned out that we really didn't need the temporary large facilities housing 300, 500 persons, because the pandemic at the end, it wasn't really as much as we thought it will be, which is really good in any case. When we started, we had only about 250 ICU beds. We've subsequently increased. We now have just over 500, but that's still insufficient for a population of just about 200 million. One of the key things that we're doing is to improve oxygen delivery and the oxygen security for the country. And we're in the process of constructing oxygen plants throughout the federal hospitals in the country. And I think this is something that would really provide improved survival in the long run, even after COVID, because a lot of hospitals don't have access to easy oxygen. So risk communication was another thing that we really prioritized. We've trained over 62,000 persons on risk communication, and we've really relied on platforms such as the polio eradication program. There were loads of community volunteers that we were able to mobilize within a short period of time, over 800,000 nationwide. Nigeria, by the way, is quite a large country. It's about 4 times the size of the UK. So you can imagine the sort of work that's required to reach out to people that are less literate than what you would find in the West. And then, of course, the economic impact has been huge. The economy in Nigeria has really shrunken. I think we've lost about 23% of our entire GDP as a result of COVID. It's been huge. A lot of people have lost their jobs, and there's a serious risk of civil strife over the next few months to a year. So there's been a lot of distribution of what we call palliatives, food, to 3.5 million households, national social register with money being cash transfers. They call them cash transfers, but really this is affecting probably less than 5% of the population. So this is our epidemic curve. It's really coming down. We plateaued, but we're still not very happy with the number of tests we're doing. We've done just a little below 500,000 tests, which is really insufficient. And one of the challenges is that people are just not testing. The issue of stigma and discrimination has really affected our ability to upscale testing. People are not interested in coming out when they have symptoms. They don't want to test. They don't want to know. They would rather just see it through. So I've mentioned some of the key challenges. So the treatment centers, they've turned out to be empty beds really. So what we're now trying to do is to move the equipment and the assets back into a newly constructed infectious disease unit. We will now have infectious disease units throughout the country, all 36+1 states. And each infectious disease unit will have about 45 beds, of which 5 beds will be ICU. And it will really help when it comes to future pandemics, particularly Lassa, the Lassa fever, hemorrhagic fever outbreaks, and as well as Ebola. So really improving sustainability in the long run. Testing, I've mentioned our target. We're very far behind. Our initial target was to test 1% of the population and then 2% of the population, but we're really very far off. Lockdown has really caused financial hardship, but I think with the reflection, we really did the right thing because the lockdown really provided us with the opportunity to get on top of the problem before it got out of control. And then, of course, ownership by the state. So the Nigeria structure is such that the state governments are very powerful. We have a federal structure. The states are responsible for health. They're responsible for education. And the federal really just provides direction. But sometimes there's always that clash. We had governors that did not really believe that COVID existed. Welcome to some. I think it's not unusual. Even in the West, we've had similar situations, I guess. And this has really posed a problem in terms of our ability to implement programs right down to the grassroots. So sample collection, a major issue, but this has really improved significantly over the last 2-3 months. One of the biggest challenges we have really is the issue of disbelief. And this is really driving the perception, the low risk perception among the population, which is evidenced by the non-adherence to simple non-pharmaceutical interventions. Although people do wear face masks, but it's increasingly, when I go out nowadays, I don't find people wearing masks, and the enforcement side is incredibly difficult, as well as the issue of physical distancing. And then I've mentioned the hotspots. And I think in terms of strategies, this is one thing that maybe we should have started doing right from the beginning. Now that we've identified the hotspot local governments, we are putting a lot of resources into them. And that's what's actually influencing the curve, because things are starting to settle. It looks like not all the countries, the epidemic is really mixed. It's heterogeneous. It's not really across, it's not uniformly the same. And it's definitely reduced excess mortality as well as reduced the rate of spread of the infection. So what lessons have we learned? Well, there was a delay in closing both the international and local borders. Maybe we should have done that much earlier. But having said that, I think inevitably almost every country in the world now has COVID. We would have ended up with importations anyway. Partners, proactive engagement of partners, although I think this is actually a strength. We've had a really effective partnership. I've never realized how effective the private sector is until now, because we engaged the private sector to help us with some of our interventions, and the speed at which they were able to deliver was just amazing compared to the bureaucracy of government. And I think, to me, this is one of the lessons really. If you really want things to work, you've got to involve the private sector. You've got to have some sort of arrangement with the private sector. And then the late involvement of the Ministry of Education was also a problem. We're trying to open up the schools now, but we've realized a lot of the schools just aren't ready. Some of them do not even have basic hand washing facilities, etc. And a lot of them don't have access to internet. So a lot of children have been at home for prolonged periods of time. So inadequate PPE was a problem. It's becoming less of an issue. We are now introducing local manufacture. We've always had local manufacture of sanitizers, gels, etc. But now we are in the process of becoming more having more adequate PPE because we don't need to import them anymore. And then the limited focus on economic recovery. Most of us that run the technical side of the response were medics, and therefore approached things mostly from the health side rather than looking at things from the overall perspective of the economy, etc. And I think this has really affected us. And then, of course, the monitoring, the issue of travelers and monitoring. We are now just about to start using a contact app, tracing app, which we hope would help with opening up the international airports. So what do we intend to do? Clear strategies, risk communication is really essential. It's all about changing behavior. If you do not have the buy-in of the communities, you will not be able to implement anything, especially when it comes to health interventions. And this is a lesson that we have learned quite late. We've realized that engaging the traditional and religious leaders is the only way we can address the issue of denial and low risk perception, because they're the ones, it's not really the message, it's the messenger. We've got to change the messenger. People do not believe in government. There's always a lot of mistrust. They don't believe in leaders unless those leaders are part of their community. And then we are also looking at the exit strategy. The task force was set up as a start and finish task group initially for 6 months. We've just had an extension till the end of the year. And we're looking at strategies that will enable us to safely transition to some of the core duties back to the ministries and departments. And we continue to have targeted intervention in the high-risk areas. We've just stopped isolating people now that are asymptomatic, and we've introduced home-based care for those that are relatively well. We've established community support centers, and we are increasing sample collection centers across the country. And then finally, we are opening up the economy, because without a strong economy, we cannot really recover. And to me, the post-COVID phase is going to be a lot more challenging than what we have faced. Africa has been relatively spared the mortality that we've seen in other parts of the world, but it hasn't been spared the economic impact. It's been huge. So in summary, I think it continues to be a very challenging environment to operate in. The systems that are in place are still fairly weak. We are exploring local production of PPEs and medical equipment. I think if there's one lesson again that we have learned is the need for local sustainable solutions. Secondly, the need to regularly review programs is critical. We realized, for instance, quite late on that we are not going to have the sort of mortalities that we thought we had, and therefore we had to switch more towards sort of community engagement and community-based interventions rather than the clinical side. And of course, partnership is key, and we've got to maintain the momentum. We can see what's happening in the West now with the possibility of a second wave, and it's frightening all of us because we're all very fatigued. We're really tired. We want this to be over, and we don't want to go back to those days in March, April, when we were having sleepless nights trying to push through interventions that communities were not happy with. So I'll stop here, but thank you very much for the opportunity, and look forward to further discussions. Thank you.
Thank you so much, Sani. That was fascinating, as all the presentations have been. So thank you, and a huge amount of responsibility you got there in coordinating that. So thank you for giving us, and fascinating to see both the similarities and differences that apply to here. I mean, I can see a huge number of similarities, but some differences too. So it's really interesting to see that. So colleagues, I think we could probably spend the next 3 or 4 hours discussing this, because there's so much rich material in what colleagues have said. But I'm very conscious that actually we don't have that amount of time. Unfortunately, we only have about another 10 minutes in total before the Zoom connection disappears. So Thinn, if you want to just open up your video connection again, and then everyone can see all the panelists, that's great, thank you. And so what I'm going to do, if the panel are okay with this, rather than us having a conversation amongst ourselves, which, as I say, I think we could carry on for hours, I'm going to address some of the questions that have come through from colleagues who are watching this. And so let me just read out questions. Now, for colleagues who've or observers who've raised questions, we may not get through them all in the time that's available to us. But if that's the case, we will nonetheless put answers up on the website so that every question will be answered, albeit we might not do it all tonight on video. So first question we've had up is that the COVID-19 pandemic has put up unprecedented pressures of time on clinicians who formerly might have put their time into global health projects in their spare time. And given the risks to both established projects and fledgling projects of potential clinical absenteeism, is it time to think about how we might have properly funded earmarked time in clinician jobs plans to ensure their continued contribution? And if so, how might that be achieved? Evelyn, no, well, I'll come back to Evelyn a bit later on that point, because I mean, she'll have seen this across the piece, but just Jamie, you're in Cambridge at the moment. What's your sense of that debate and discussion within the consultant and clinical and nursing community in the hospital at the moment?
Yeah, so I think the first thing to say is that, I mean, we're fortunate in Cambridge that we've got sort of buy-in from the leadership in the hospital to be involved with global health projects. And there's time that we can spend on these projects. But I think, I guess the point that's being raised is about sort of deeper involvement in these projects and giving more of a commitment and having it sort of built into a job plan so that you can be doing clinical work and then having big blocks of time that's supported by the trust to do global health work. I mean, obviously you wouldn't be a full-time clinician and the funding would have to come from somewhere, but I think that would be a very attractive thing for people in terms of recruitment and retention, but also getting very involved in these partnership projects at a deeper level. So I think that would be a very positive thing to do. I just think we have to be very creative about how you'd actually fund that going forward. I think within the region, I mean, Evelyn and I have been speaking along with other colleagues who are not on this call about establishing global health training within the east of England. And there's a lot of buy-in from various specialties to try and support that. So I guess this could be linked with that in some way, which would be a possibility.
Yeah, that's really helpful, Jamie. I mean, you made the point in your presentation that, of course, people aren't able to engage in a project in the style and the manner that they were before because they're going out and visiting for a fortnight or 3 weeks isn't tenable at the moment. But on the other hand, you've seen more video and other immediate connection on a different kind of basis. Do you think, has there been a net reduction? You may not be able to have a sense of this, but has there been a net reduction in our ability to provide support, or has it maintained itself, do you think?
I think in terms of the overall support, given the fact we've got technology to support it, has actually probably been okay. I think the issue would be about trying to establish projects when you do need to have time in country to do that. So established projects can be supported by ongoing dialogue. I think establishing a new project or branching out in new directions, this is where this is going to be limited given the constraints that we're under. And where having kind of more time to do that would be a very positive thing. But you know, we've benefited enormously from technology in supporting our partnership.
Okay, thank you. I'll move on then to the next question, which is that lockdown caused hardship for children with disability, particularly in getting medicines and treatment. And how can this be addressed at a local level? Now, I think the question is about the consequences of the existence of COVID have had effects on other groups of patients, not that those patients have themselves suffering with COVID, but it has the knock-on effect on other patients. You've had that experience, well, both Thinn and Sani, you've had that experience in Myanmar and Nigeria respectfully. Mm. Can I ask that Thinn on this one, and Sani, I'll ask you on the next question. Thinn, how have you coped with the consequences of the COVID on non-COVID patients and their ability to access treatment?
Yes, it is hugely challenging in Myanmar because the hospitals, public hospitals, are functioning towards COVID. There has been less capacity in terms of outpatients capacity as well as inpatient beds has been greatly reduced for non-COVID patients. That includes medical, surgical, and also pediatric services as well. And also, even in the community, general practitioner, to see the general practitioner, because of the anxiety and the concern of the general practitioners getting exposed to the COVID. Some of the general practices, both in the cities and the rural areas, might be closed when they were open otherwise. So there has been a significant knock-on effect. And especially now, because of the rise in COVID-19 cases, the public hospitals cannot provide the ongoing elective and outpatients, non-COVID outpatient clinic services, because they are dealing with emergency cases and only COVID patients at this moment. So it is beyond words how these patients have been, put on with great pressure.
Yeah, thank you, Thinn. I absolutely. I see that in Cambridge too, and it's deeply worrying. It's been worrying for a long time. Can I ask Sani the next? I think this is going to be the final question we'll be able to ask tonight, and we'll have to keep it brief because the Zoom clock is ticking away. But Sani, the question is that it's the one that I know worries us a lot, which is the UK takes doctors and nurses from across the globe in order to provide services to the National Health Service. And yet it is often many countries. So, for example, African countries, India, subcontinent, Southeast Asia, where clinicians are coming from. And those services are in need of those clinicians, and how do we balance that thing and the ethical challenge? I personally feel it is a very deep ethical question and a problem for me that the UK relies so much on doctors from around the world. How have you seen that play out in this, and do you think there's a long-term consequence of the pandemic for this debate?
So certainly from the perspective of Africa, there have been concerns over the last few months because it's not just the UK, it's also other Western countries as well, particularly the United States that have opened up and relaxed restrictions, visa restrictions, etc. There was a whole plane load of medical doctors that was stopped from flying out of Nigeria in the midst of the clampdown. Somehow they were able to get a private jet to come in to pick them up, about 50 or 60 doctors, and they were stopped from flying, but they subsequently found their way through the land border to neighboring countries and were still able to get to Europe. So I think in a way that reflects the desperation because as we all know, the world is a competitive, generally speaking, the world has contracted. We're more or less like a global village. It's not difficult to get from one place to another, and neither is it difficult to compete for posts, etc. And I think the solution to this is to have bilateral arrangements with countries. There are countries that do produce excess doctors. There are also countries that do benefit from having people that are exposed to the Western way of doing things. Like for instance, I came over originally from Nigeria. I've been in the UK since '97 or so. And I've really benefited from being in the UK, and I've been able to take back some of the things that I've learned back to Nigeria to help with the system. So there are benefits, but in the long term, I really think that what we need is a solution that will benefit both countries. In other words, having some sort of electives or training periods where doctors are allowed to come from the developing world.
Okay,
a year, 2 years, etc. Yeah, and then go back in.
Yeah, I completely agree with that. So I am going to finish now for my bit, just to say a huge thank you to Jamie, Thinn, and Sani for really enlightening presentations, which just show the enormity and both the similarities and differences. So a really profound thank you, both for tonight and for what you are doing throughout. I'm going to hand over to Evelyn, who's going to bring us a link to the charitable donations, and then Evelyn will close. And I'm conscious that the Zoom clock has already probably reached 6 o'clock.
Thank you, Mike. Yes, thank you very much. Now, you're asking me for the because what we wanted to just ask everybody was that if you feel minded, we have recently launched a fundraising appeal to continue the work that Jamie spoke about in terms of supporting our partners in Uganda. And what we will do after this is send an email to you all with that link, and I'm about to put it in the chat, which will take you and tell you more about the project, and also allow you to donate, and also if you would share it would be fantastic. But really I just wanted to say thank you to Mike, thank you to Sani, to Jamie and to Thinn, because without you we wouldn't have this evening, but much more importantly, without you we wouldn't have the fantastic global health partnerships that we do, involving Cambridge clinicians and many other staff and students, but equally our partners overseas. And I think what we've done in Cambridge is to, in many ways, lead the way on much of this. And I think we've also recognized how we benefit in three ways: the individuals who are involved, the organizations, and then the organizations on both sides, the partners in low and middle income countries, and then the institutions in the UK. And we must continue that. And I think, well, I hope that we continue to lead. And I think embracing things like we were discussing earlier about, you know, how can we take part in some of those bilateral arrangements about sharing staff? How can we give clinicians and support people with more paid time to really get immersed in global health activity? So thank you everybody for joining, and thank you for your really good questions. There's a wonderful question from Andy Leather at King's Global Health Partnerships, which I look forward to pondering with my colleagues about what three things have Cambridge Global Health Partnerships learnt from this. And I think there's so much that equally within this community of King's and Cambridge and elsewhere that we can continue to develop. And you know, COVID has kind of thrown us quite a ball to carry, but equally there are opportunities that we've discussed that have come out of it that we must embrace. So thank you everybody, and thank you particularly to Mike and to our three panelists.
Well, thank you.
And good evening,
thank you to you, for all you do, and for Sophie for organising, and Christian for helping us tonight as well. And I'm sorry we had to curtail it so quickly.
Thank you.
Good evening, everybody.